And we're live. Hi, everyone. So, as usual, for those of you who are new to Talking Live with Macy, we'll wait for 15 people to join us on the stream so that we can get more viewers before we begin. So, during this time, I would like to ask you, all of you, to share this live video with your friends, with your family, with your relatives, because this is in conjunction with Breast Cancer Awareness Month. We need people to come and join in to ask questions, be aware. This is a public education program that we are bringing to everyone to be a part of it, to know more, not just about breast cancer, but to give people hope. So let's hope that more and more people will join us so that we can officially start the show and all of you can start asking questions as well. So we have an expert on the show with us today, and I'm very, very excited to have him on. I can't wait to introduce him, although he is already on the stream. But I want you guys to please do share this with your friends, with your family, with your relatives. Get people to join in because it's very rare that we can get our expert here on the show, especially on a Sunday afternoon. And and I know that there are many people out and about already. Things are opening up, that's for sure. And I know a lot of people are going out, but please remember practice the SOPs. I'll give it about 20 more seconds before I officially begin. The numbers are going up, so guys, get people to tune in so they can ask questions with our expert as well. And we need people to know and be more aware, especially not especially females actually, about breast cancer. And this talk today, it will actually give people more hope, especially early stage breast cancer patients and survivors. So I know that many of you have shared the poster and you said that you'll be tuning in. And I know it's a Sunday afternoon. And it looks like there are more people joining the stream, and we already have 15 people. So I'm going to officially begin. Welcome to Talking Live with Macy. It's good to see all of you again after 2 weeks. For those of you who are new, this is a bi weekly show where we talk about health and wellness topics. And we want to encourage people to know and be aware as it is a public education program. And today's topic is in conjunction with Pink October 2021. Yes, everyone, it is already October. Time flies by so quickly, especially during this pandemic. And the first episode in October for Talking Life with Macy, of course, will focus on breast cancer awareness. Now, today's topic, as you guys can see from my poster, is for early stage breast cancer patients and survivors, and basically whether chemotherapy is needed for them. I feel that this topic is very exciting. It excited me because I feel that it's very important for early stage breast cancer patients and survivors to know more and also have hope. So, for early stage breast cancer patients, many are usually unsure whether to take the route of chemotherapy or not after a lumpectomy or mastectomy. So today we'll discuss about an early stage breast cancer assay that is able to accurately assess a 10-year risk of distant recurrence with a personalized prognostic score called ProSigna. It has been validated in various studies on 5,200 patients, and it is also able to classify tumors into four subtypes. It provides more accurate estimation of risk. So it has so many good things and validation about PAM50, or rather ProSigna, that it's very similar to sort of an immunoscore I did for my own tumor in March early this year for colorectal cancer awareness. I talked about it. But this time we're going to talk about breast cancer. This is an assay of prognostic immunoscore, which is good for early stage breast cancer patients and survivors. So, as I mentioned, we have our expert here today. He is the medical director and consultant clinical oncologist at Beacon Hospital to share more with us. We have Dato Dr. Ibrahim. He is really famous. When I posted his poster up, a lot of people texted me and say like, oh, he has treated their moms, or he has actually treated them himself. So I'm so happy to have you. Hi, Dato Dr. Ibrahim.
Hi, good afternoon. Thank you
Good
for your
afternoon.
invitation.
Thanks for coming on the show. So I'm just gonna, before I jump straight to the questions, for those of you who are tuning in, please right now you can start putting in your questions so you don't have a backlog of questions towards the end. And all of you can actually ask questions now, and we'll pick it up after my Q&A with Dato. So Dato, I'm just going to jump straight to the first question. What are the most common types of breast cancer, and is breast cancer curable?
Okay, I'll answer the second question first because I'd like to open up with a very sort of optimistic note. I say, yes, certainly breast cancer is definitely curable, especially if they are early stage of breast cancer. Now, the issue of the common type of breast cancer, things have changed. When I started my medical school training, when I started to learn pathology, we learn about, the sort of the pathological diagnosis or uh, classification, where you talk about invasive ductal cancer, where the cancer is mainly from the ducts of the breast, the sort of milks,
Mm.
cells that are
Yeah,
lining the ducts,
yeah.
or you talk about or you talk about the lobular type of breast cancer, and then there are variants of those. Yeah, so most of the time we see invasive ductal type. Then you don't. Then you see the lobular type, and then the much rarer subtypes like the mucinous, the
Mm.
papillary, and then neuroendocrine, and then some of the adenocystic, and some of the aggressive one like the metaplastic, which fortunately is quite rare. But things have changed, But now we are also looking at the molecular profile and subclassifying them, like either they are luminal A or luminal B or triple negative breast
Mm.
cancer,
Yeah,
or even HER2 enriched. So we're talking about luminal A, where they are hormone positive type of
positive.
breast cancer,
Yeah.
ERPR positive, HER2 negative. Then you're talking about luminal B, they are also hormonal positive, that they may have some degree of high features like Ki67 may be high, or it may be HER2 positive. So we are looking at molecular subtypes, because they reflect uh, uh, risk of recurrence and prognosis slightly better than the just the basic pathological classification.
So with technology comes hope for a lot of breast cancer patients,
Hmm.
right?
Yeah.
That's very good to hear. So my second question then would be for patients with early stage breast cancer who have undergone surgery. Is there a need for further treatment with chemotherapy?
Okay. The answer is yes and no, because what we look at is risk factor. If you have a high risk factor of recurrence, then you need chemotherapy to help to lower that risk of recurrence. If your risk factors are low, then generally don't need. So again, we classify risk factors sometimes looking at the size of the tumor, the number of lymph nodes that are involved when you do surgery, the grade of the tumor. Now I have to classify, the grade and staging are different. Grade is just one, two, three. Grade looks at the pathology feature and see whether the cells look, they are fast growing or aggressive type, or low growing. So they are low grade, low growing, low um, um, sort of dividing cells, slow growing cells. We put them as grade one. If they are rapidly proliferating, rapidly
Mm.
growing, we look at them as grade three. So grading is different. So high grade is not a good thing, low grade is a good thing. Then we look at hormonal factor, whether they're hormone positive or hormone negative. We look at their HER2 receptors, whether they are
Yeah,
HER2 positive or HER2 negative. We look at menopausal status, how
yeah.
young they are, how old they are. So all these sort of features are what I would say as like physical features, and we classify them whether they are high risk or low risk. So somebody with a large tumor, high burden of lymph nodes, hormone that are negative or HER2 that are positive, we say, hey, you need chemotherapy. But patients who are, postmenopausal with a small tumor, 1-2 centimeter tumor, hormone positive, no lymph node, low grade. They are low risk patients, and most of the time they don't need chemotherapy. And of course, the difficulty is there are patients in between these types, and you don't really know whether they will benefit from chemotherapy or whether they will not benefit from chemotherapy. So this is where sometimes profiling their tumor based on the genetic profile of the tumor helps us to be a bit more accurate in our in advising them about further treatment.
So after you profile the tumor, which is like, for example, what you mentioned earlier, then
Mhm.
you're able to tell whether chemotherapy would help them or not, right?
Correct,
Based on the
correct.
types. Okay.
Hmm.
So that's to clarify
Yeah,
for those of you who are wondering. And then my next follow up question to that would be for patients with early HR positive breast cancer. There are many who are cautious, as I mentioned earlier, about receiving chemotherapy. So, is there a good reason for them to be cautious about chemotherapy?
of course, chemotherapy is not without side effects. It can cause a lot of complications, not only hair loss, tiredness, nausea, vomiting, blood count drop, makes you more susceptible to infection. And there are also a group of patients who can get something called chemo brain. It does affect their memory a little
Yep.
bit, so they can be a little bit more forgetful, and sometimes there's a very, very low risk of other malignancies. So, where possible, we don't want to give harsh treatment to patients. We want to be selective on who actually needs chemotherapy. And those patients who actually needs chemotherapy and make sure that they benefit, uh, are the ones we would advise them to have. It's not that sometimes, you know, I don't understand. Sometimes the doctor, when patients go up to them, oh, do I need chemo? And their answer is, it's up to you lah. You want to have chemo or not? I mean, that's not a satisfactory answer, because we as clinicians, we have to guide patients on hey,
Yeah.
yes, you need chemotherapy, not to say it's up to you lah, suka hati lah, you want to have chemo or not. I think that's that's not the sort of
Yeah.
answers that I would like, to give as a doctor. And and I'm sure as a patient, they might not, hey, you're the doctor, you tell me whether I need it or not. you know so sometimes what we do is, if we are a little bit uncertain, we try to make the patients understand why they need treatment. I think making the patients understand why they need treatment is very, very, very important. So sometimes it's not telling, hey, you need chemo. Why you need chemo? Because I'm the doctor, I'm telling you you need chemo. That's not a correct answer as well. You need to explain, hey, you need chemotherapy because we have done a certain test and you have a certain risk factor. And therefore, you need to have chemo because by having chemo, it will reduce your recurrence rate by 20, 30, 40%, and it will improve your survival rate by X%. And therefore, it is advisable that you should go on chemo, because not having chemo would mean putting you on a higher risk of recurrence, and that when the cancer comes back, it would be more difficult to cure you. So
I see.
sometimes explaining the patients carefully, with advising them and giving them the knowledge, the power and the power of knowledge and understanding about treatment. That is the most important thing.
So I think that is very good to note for especially for all those breast cancer patient survivors out there. I think you mentioned earlier about tumor profiling and prognostics. That's how you're in a way able to determine which subtypes and whether they need chemotherapy or not after surgery. So can you share more about that and how it works for all of us who are laymen?
Okay. Okay. I mean, there are a group of patients. Sometimes, like I say, they are sort of sitting on the fence. They are, so they may have some good features and maybe some not so good features. And sometimes, you really want to decide whether do they really need chemo or not. That's number one. The other group of patients, there are some, doctor, I don't want chemo. Then it says, but, you know, uh, or they say, at all costs, I want to try and avoid chemo. So sometimes, it's not, so you need to be a little bit more practical based on facts and based on patients' tumor profile. So you can then tell them, look, let me do this test. Things like there are several tests in the market, like Oncotype DX, Mammoprint. So that was, and now the new generations or Gen 2 is like profiling called PAM50 or Prosigna, which is something now quite popular that I use quite a bit because I found it very, very useful, is to send these patients for profiling and then be able to tell them whether or not they need chemotherapy or chemotherapy really necessary. Because when you profile your tumor, it will be able to give you what we call a risk score, risk of recurrence, or where, and will put you in a high risk or in the low risk. So if you're in the low risk, you can then assure the patient, so look, you're in the low
Mm.
risk, you don't
Yeah.
need chemotherapy. Let
Chemotherapy.
me let me give you an example. I had a patient who came to see me for an opinion. She had previously gone to a neighboring country to consult, and because she had sort of borderline, but with some high risk features, like she had, I think, one or two nodes positive.
I see.
And so the doctor said, you need chemotherapy, because you got nodes that are positive, you need chemotherapy. So the patient saw me and says, look, doctor, is there a way I can avoid chemotherapy? So I said, look, you have node positive, but, one or two nodes positive. But I said, there is another way. Let's profile your tumor, and see whether you're truly high risk or low risk. So I sent the patient for further testing, and a couple of weeks later, the test came back and put her on low risk. So I was like, hey, you got node positive, but you're low risk. So I don't need to give you chemotherapy. So I just put her on hormonal therapy, and this was like almost 10 years already, and the patient is still free from cancer without
Wow.
a single drop of chemo being given to that patient. So there are patients you can select and you can confidently say. On the other hand, recently I also had some patients which I thought was borderline low, and then I said, look, I'm not sure. I better profile you. And then I profiled her, but it turned out that she was high risk. So I said, look,
Okay.
you have no choice. I've got evidence here. Not only it's not my opinion, but this is based on
It's like
a test,
like science.
technology, a test that looks at
Yeah.
your cancer cells.
That's
Not looking at
amazing.
everybody else's result,
Yeah.
looking at your own cancer cells, profiling your own cancer cells, and seeing that, hey, you have some features there that are unfavorable that requires further treatment in order to put you in the cure category. Yeah. So I think profiling like PAM50 is very, very important because it looks at a lot of things. So it's not only putting like a risk score, but remember just now I told you about the different category, luminal A,
Yep.
luminal B, and all that.
Yep.
Sometimes these PAM50 will be able to classify you a little bit better. Now, one of the most interesting things, yeah, okay. Now you're talking about, okay, if you're hormone positive, maybe you're slightly lower risk, so you don't need chemotherapy or whatever. But hang on, if you're hormone positive, but if your hormone positivity rate may not be high, maybe 20, 30%, or, lowish side, you know, then how does that put you? Are you, are you comfortable just putting you on hormone? Because if you're 1% positive, you're also hormone positive. Yeah. If
Right.
you're 100%
Right.
positive, you're also hormone
It's
positive.
still
So
hormone
anything from
positive.
one, yeah. But the 1 or 2 or 3% who are hormone positive, how well will you do compared to your very, very strong hormone positive? So I think in category groups like this, where you are borderline, and then if you are like also borderline HER2, are you really luminal A or luminal B?
Mm.
So I think in situations like this, it definitely will help, to profile these patients. And
Okay.
the only
Thanks a
thing
lot.
is when you profile this, is, of course, it comes at a cost, but I think, it is at a very reasonable cost. And I think it will help patients and help doctors like me to be, to give you a better understanding, and also for me to understand your cancer a little bit better so I can advise you appropriately about whether you need chemotherapy or not.
Thanks a lot for sharing about your case studies with your previous patients and also your current ones. I think that alone is enough to convince, let's say, if I was an early
Mhm.
stage breast cancer patient, I think this is something I would definitely consider. And for those of the audience, just to let you know, notes means lymph nodes. If you were wondering, so yeah, I just need to explain in case people
Oh
get
yeah,
lost.
that's a good point. Yeah,
Yeah,
yeah, yeah, good
so
point.
it's
Lymph
lymph
nodes, yeah.
nodes that and when Dato mentioned nodes, um, okay, so then you would say in your terms of for example, your experience with Prosigna or PAM50, you wouldn't use it for all patients, but only selected groups that benefit from it, right?
Correct. Because if let's
Yeah,
say you are clearly triple negative, that means you have hormone negative, ERPR negative,
yeah,
HER2 negative, um, you need chemotherapy, because there are no, you're not hormonally driven.
mm,
And there's no, so we can't give you hormone treatment. So in this sort of situations, you clearly need chemotherapy. Or sometimes when you are HER2 strong positive, HER2 positive, HER2 is not a good feature to have, but we can control the breast cancer with anti-HER2 treatment. So you do need chemotherapy with your anti-HER2 treatment. But those who are hormone positive with some good features, what you want to do previously is we are giving a lot more chemotherapy. But the question is, can we select out some of those hormone positive patients with good features? Can we select them out and not to give them chemotherapy? So that is the
that's true.
crucial uh, issue here.
So that's why I was really excited to have this session because I feel that tumor profiling is it gives early stage breast cancer patients hope and survivors as well. So talking about Prosigna and PAM50 and the fact that you actually have used it before, Dato will be conducting a trial perhaps early next year on this, and he's actually looking for participants. And if you're interested to be part of the study, it's called the Optima study using PAM50 per Cigna. It will be held at Beacon Hospital. You may contact Beacon Hospital for further information. And I think I have my last question, and that means to all of you who are watching, staying tuned to this whole time. I think it's safe to say you can start asking more questions now. Please put in your questions so we don't have a backlog of questions after my last question with Dato. So please start putting your questions, typing it in now in the comment box. So Dato, my last question for you is, Prosigna is commonly recommended by the international guidelines as ESMO, ESCO, and in many countries like the UK to be used in HR positive early breast cancer patients with lymph nodes negative of up to 3 nodes positive. What happens if there are patients with larger tumor or with 4 nodes positive? Will Prosigna be helpful?
Yeah, I think that's a good question, and I think this is an area where we need to do a lot of clinical study. See, a
Mm.
lot of people have very distorted view. Clinical study means we're experimenting with you. No,
Yeah, no, I
clinical
disagree as
study
well.
is not about experimenting. It's about finding answers to questions that are ambiguous or that are
Yeah.
uncertain. whether you need chemotherapy if you have X number of nodes or a certain size of tumor. So you do a clinical study, and then you look at the performance or outcome based on the treatment that you have given, and then you can find and select out. So doing a clinical study is very important. Like we say, we are trying to do this Optima study. The study is called Optima
Yep.
study. It is running in the UK and some Scandinavian countries in Europe. We will be the first center really in Southeast Asia to be
Wow.
doing this study. So we are the only center that's been selected by the trials committee out of the European sort of catchment. I think there's one study in Hong Kong, but and then and us, so we are the only sort of. So we are proud to be associated with all these eminent researchers from Europe lah. So we'll be doing this study, but please be patient. We're just getting all the paperwork. To do a clinical study, you need all the
Yeah.
paperwork and ethics committee approval and all that, so that we were able to offer this as a study. So when we do this study, so we'll be doing the research and all that. So the cost will be bared by the study sort of funds, lah, as it were. So patients will not have to pay anything if and when the study comes in a bit later on
That's
in the
why.
year or early
That's
next year.
why. Echoing your thoughts, that's why I always feel like clinical studies are actually pretty positive for cancer patients and survivors out there, because it helps with the cost, and also you are part of contributing to science, and
So,
the trial may actually help you a lot. So that's why I've always encouraged when people ask me, should I go for the clinical trial and things like that, especially cancer clinical trials. So that's my thoughts on it. Thanks for sharing your
thank
thoughts
you.
on it, Dato. Now I'm going to start taking questions from the audience. And if you're tuning in and you have questions, I think it's time to put them in now. I'm going to start all the way from the top. Um, I'll just hi everyone. I see all of you saying hi. I think Samuel had a question about food restrictions for breast cancer. Are there any food restrictions for breast cancer?
That's a common question everybody asks. My short answer is eat a proper, well balanced diet. A lot of people come pantang this, pantang that, don't eat this, don't eat meat. There are 10 different people who will tell you not to eat 10 different things, and you end up eating nothing. That's, I think,
Yeah.
is dangerous to me. I mean, some people suddenly become totally vegetarian just because they have cancer, and then they lose a lot of weight. That's not
Yes.
a good thing. So you need to eat a well balanced diet, and you need to eat a proper diet. What I would say is, yes, you need to eat a healthy diet that hasn't got too much of all these artificial ingredients, ajinomoto lah, oyster sauce lah,
Mm-mm.
or whatever, all the artificial ingredients. Eat natural, well balanced food, and try not to eat too much, like, things like sausages and all the artificial stuff lah. Just a well balanced diet.
Okay. So, like, how is he had a follow up question on how breast cancer is diagnosed? How is breast cancer diagnosed? He asked.
Okay, breast cancer can be diagnosed in sort of several ways. Sometimes when the women accidentally finds a lump
Lump.
in the breast, and then goes for further examination, and it turns out to be cancerous. So what are the further examination? They can undergo mammogram or ultrasound as a preliminary test. So, and then they are found that out that way. So generally, when you find a breast lump, and then when you do the test, generally the lumps are a little bit bigger, because in order for you to feel, the lumps
Yeah.
have to be maybe more than 1 cm, 2 cm. So they are generally quite big. The other way is in Western countries, it's very common. It's called mammogram screening. or it's called breast cancer screening. In Malaysia, unfortunately, the uptake is not very high. One of the good things or advantages of screening is it can detect very, very small tumor, or even before the cancer becomes invasive. It's what we call DCIS, or ductal carcinoma in situ. So it is still like stage 0, you know. So undergoing mammogram, especially after a certain age, normally here we say 45 and above, or if you have a strong family history, maybe a bit lower. Doing mammogram screening is very, very important so that we can
Yes.
detect the cancers
Early.
early. Sometimes the mammogram has to be supplemented with ultrasound, but certainly radiological examination will help to find those very, very small cancers, or before they become invasive cancers.
Okay. I think he had one more question. How many cycles of chemotherapy for breast cancer is needed in the earlier stages?
Oh, okay. That's a very, very difficult question because it's
Yeah,
based
I think
on
so too.
on how the patients generally, we say about 4 cycles, sometimes 6 cycles. I
Mm,
have given patients as high as, weekly 12 doses times four, about 16 doses. So it very much depends on the type of cancers, the risk category, uh, and menopausal
yeah,
status, etc. So it's it, it's
it's a
you
tough.
know
It
it's
depends on the
yeah,
person.
it depends on the patient and depends on the doctor, because sometimes
Yeah.
Dr. A will say you need 6 cycles, Dr. B will say, oh, you need 8 cycles. So I think it's best to consult the oncologist,
Mm,
and they will be able to advise you appropriately for that particular patient.
okay. So Dato, you have one of your patients here, Mi King Ting, and she says that you cured her,
Okay.
and she likes you 100
Okay.
times. So
Okay, hi.
uh, Uh, I have a next question from Dabanan. Can a lady who is age 40, who only does breast ultrasound checkup, can she do it instead of mammogram yearly, just ultrasound without the mammogram?
Okay, I think sometimes we do use ultrasound for patients with a very denser breast, because it's not easy, especially your premenopausal. It's not easy to see a lump hidden in a dense breast. So sometimes you need to do ultrasound to see it better sometimes. But combining mammogram with
Mm,
ultrasound, I think gives a slightly
better.
a better pickup rate, as it were.
Okay.
But there are some newer generations of mammogram with what they call the tomosynthesis technology, where they finely cut the slices on the X-ray, and you can see sometimes a little bit better. But so I think it's best sometimes to discuss with your doctors to understand, if you have a very dense breast, might be
Mm,
difficult to see on mammogram. Yes, I think ultrasound is helpful as well, but sometimes you might need to combine the two to get better
okay.
reading.
Thanks for the advice for women who have dense breasts. Now, Kazin asked whether Prosigna was derived based on postmenopausal studies. She said, can it be used for premenopausal women? And if yes, how accurate, reliable is it for premenopausal?
Yes, I mean, it started off with some of these tests on postmenopausal, but now we are looking at premenopausal, so it's
I
not an
see.
age sort of thing. I mean, the study that we are looking at is looking at patients who are, premenopausal as well. So
Mm,
there is no sort of cutoff. But there are certain things. If you're very, very young, uh, you know, in the early 30s or in the 20s, sometimes it's a bit more difficult to know how well some of these tests, because we tend to be a little bit overcautious, or we tend to be a bit more sort of aggressive, because young patients who are below the age of 35, their survival rate is not as good as patients who are above 35. A long time ago, when I was at the university hospital, working together with Professor Yip Cheng Ha, we analyze patients who are below the age of 40 and below and above the age of 40, and when we give treatment, equal treatment to both of these groups of patients, we find that patients who are the younger ones, they tend to do not as well as the older patients. So in a very, very young patient below the age of 35, I would tend to be a little bit more aggressive, and I would tend to give chemotherapy to these group, regardless of, sometimes they're PAM50, because I need to really sit down and talk to them. Let's say, if you look at the clinical data below the age of 35, there is about 5 to 10% difference if you're below 35 and above 35 in terms of survival rate.
Yeah, I know this because
Mm,
I lead a young cancer survivors group, and there are a
mm,
few of them in my group that have already passed on. So
mm.
and they are, I mean, they are the younger age group. So yeah, and I mean breast cancer as well. So yeah, it's thanks for sharing that, Dato. And I hope that answered your question, cousin. Now, Fiza Rahim says that she's taking tamoxifen about six. Can she still get pregnant? She was diagnosed with breast cancer HER2 positive.
Sorry, how old is she now?
Not sure how old she
Not
is.
sure. Okay, okay,
I guess
okay.
she's the reproductive age because she asked whether she can still
Yeah,
get
okay,
pregnant.
okay. I think, yeah, depends on whether she's having, sometimes after chemotherapy and after tamoxifen, you may
She's
stop your
38.
period. 38. Okay, so
Mhm.
she's, like close to. So sometimes you may stop your period. Okay, so if you stop your period, then of course, the situation is difficult. But sometimes, even despite tamoxifen, you may still have irregular period. Especially, do see it in very young age patients where they do still have regular period. But generally, if you are high risk, I think you better speak to your doctors whether, because if you want to get pregnant, you may have to stop your tamoxifen. And then the question is, you need to speak to your doctors. Is it a risky thing to do, or is it a safe thing to do? Sometimes, pregnancy itself, unfortunately, may fuel
Yes,
breast
the
cancer. And
hormones.
yes, I've lost one or two patients, when they got pregnant without, discussing with me, got pregnant, and then suddenly the breast cancer just flares up after that. And so we have to be careful. So the answer to that is, you need to speak to your oncologist, discuss it with them about your clinical features, and whether or not it would be wise to stop the tamoxifen in order for you to become pregnant.
Okay, that's interesting to note.
Yeah, because
Billy asks,
we don't want to take drugs when you're pregnant.
yes, yeah, that's true. The next question is a general question. Billy asked whether how many women are in Malaysia actually have breast cancer. It's 1 in 11 or one in
Okay.
how many?
Okay, if you look at the overall statistic, we're talking about 1 in 18, breast cancer. But then if you further divide it into sort of racial, Malay, Chinese, Indian, it seems to be higher among the Chinese, where it's about 1 in 14, 1 in 15 Chinese, and Indians also around 1 in 15, 16, 17, and
Mhm.
Malays a bit lower, lah, 1 in 20, 20 over. But if you look at the Western figures, like in UK, it's 1 in 8. So, so they are almost double or higher, two times the
Yeah,
risk compared to Malaysia. So the Western figures are more sort of a lot higher. But if we are, as we become more westernized with our ways, our diet, and all that, we could catch up with, so our numbers can only go upwards. So that's something a little bit worrying,
To
and I
watch out
think
for.
we have to watch out for. So I think creating awareness about breast cancer and all that is certainly very, very, very important in terms of early detection, and because it
Mm,
can be cured. Like I say, breast cancer early stage can be cured. And what is the cure rate? We've done in Beacon Hospital, we've looked at our survival rate, giving chemotherapy or giving treatment to patients, our 5 to 10 year survival rate. We are talking about, those with stage one and stage two. For 5 year survival rate, we are touching 100%. Stage
wow.
three, 80 over percent. But even our stage four, 5 year survival is still about 50 over percent. And so now we need an update to see, those group of patients. So we can and have cured quite a number of early stage breast cancer with proper treatment. Can be
Mm,
cured. So that's why every reason to be optimistic, every reason to be, vigilant, and every reason that we should face breast cancer with courage.
yeah, early detection is key
Mhm.
in this, fight, and to detect it early before it progresses. So Mei Lau is HER2 positive, and she's considered high risk. Um, she asked, is HER2 positive considered high risk, and that chemo is necessary?
If you are HER2 positive, you will need not only chemo, but you may need
Hormone.
anti-HER2, HER2, yeah? Yeah, she said
Yeah.
HER2 positive, and whether she is ERPR positive or not. And also, HER2, we look at your HER2, stage of facia, whether you are, look
Mm,
at the ratio, if your ratio is high or not. But you do need anti-HER2 treatment,
mm,
drugs like trastuzumab, together with your chemotherapy. You do need some additional treatment for HER2 positive
okay.
breast cancer. So if you're HER2 and hormone positive, then you also need hormonal treatment after your chemotherapy. If you're HER2 and hormone negative, then you just need the HER2 treatment, anti-HER2 treatment like trastuzumab with chemotherapy, and of course we don't follow up with hormonal treatment.
Okay, thanks, Dato. Hope that answered your question, May. Now, Shida Alwi, she was diagnosed with grade 1, stage 1 breast cancer in 2006. She only had lumpectomy and radiotherapy. And since then, she had 3 relapses. Now, in stage 3, she is PR positive, HER2 negative, and has been on hormones and CDK therapy for 6 months. She says there is not much improvement so far. So, what are her options?
I mean, she is hormone positive, so I think hormonal treatment and
Oh, she's
CDK4/6
HER2 negative,
positive,
she's HER2 negative, and
HER2 negative.
Yeah, PR positive.
So HER2 negative is good lah. So you don't need HER2 treatment. Yeah, you
Yeah.
don't need HER2 treatment. HER2 treatment, you don't need it. But she needs so hormonal treatment is very important. And nowadays, when you combine hormonal treatment with CDK4/6 drugs, uh, you tend to have a much better control. So I think all I can say is yes, she is on good treatment. Now if that um, doesn't control the disease well, then there might be other what we call biomarkers that we may want to start doing. Maybe when we do the biopsy, we want to
Mm.
see whether she's got something called like a PIK3CA or not. She got PIK3CA positive. Then there are drugs that can help to counter the PIK3CA. Sometimes we do look at BRCA when because there are drugs that can use for treatment. So sometimes we want to profile the tumors a little bit. Now,
Mm.
this is not using the PAM50, this is using the what we call the NGS lah. next generation sequencing, where we can profile and we can see where what we call are there any druggable targets that we can find in
I
her
see.
tumor. Yeah, so if she
Okay.
doesn't respond terribly well on that, we may want to do NGS to look for druggable targets.
I think that really helped Sheeta on her options. Thanks, Dato. Um, so for those of you who are tuning in, I know you guys have so many questions, even I have, but unfortunately, time is running out, and Dato has been so graciously answering all the questions. So I'm going to take just a couple more questions, especially those of you who probably need those answers now. So Dato, I'll pick and choose accordingly. Lynn Hazilina actually asked, does PAM50 actually work for triple negative breast cancer?
Okay, generally triple negative, we do give chemotherapy. So, PAM50 does have, looking at subclassification as well. But if you're looking at whether you can avoid chemotherapy by using PAM50 and see whether you're low risk, that's not going to give you the answer. So the answer is no, you still need chemotherapy.
Okay.
But PAM50 sometimes can, yeah, you can look at, whether you're sort of this basal-like tumor, which can be quite aggressive or not. So generally, no lah. When the Optima study that I'm doing is actually more on looking at hormone positive lah. Mm-mm.
Okay. So, Dato, talking about that, then, Madam you asked, but how is tumor profiling done in layman terms?
Oh, they have to use looking at the tumor. So there are a few types of profiling. This one is looking at the your risk score or risk of recurrence. Where you have many different types, like an oncotype DX, or the looking at the risk recurrence score and all that. You have Mama Print, you have PAN50, you have a few other tests where each of them you looking at the gene expression. So
So,
something
basically,
like
the genes,
PAM50, yeah,
okay,
looking at the
of the tumor.
profiling those genes.
Yeah.
So like PAM50 looks at 40 to 50 different types of gene, the expression, and then do the calculation that way, not only based on your pathology, but also on your gene expression. I think Oncotype looks at 20 over genes, So you're looking at your gene expression. So these are looking at that. Then the other type is what we call NGS or next generation sequencing. Now, generally, I use that for patients who have relapsed. Okay, so the PAM50, we have mainly like patients we want to decide about treatment and all that. But next generation sequencing, we biopsy, and then we look at the genetic profile of the tumor and we see whether there are druggable, that are looking at mutations, and those mutations, whether they have a druggable target, So like I told you, like PIK3CA, BRCA, whether they
Raka.
are druggable targets, yeah, BRCA1, BRCA2, so are there any druggable targets, or we may want to profile whether or not they might respond to immunotherapy or not. So those are slightly different. So there are different types of profiling. Yeah, I'm also doing a study called in vitro Q. That's again is slightly different. The in vitro Q study, what I do is, say for example, somebody has breast cancer who have treated, and I want to know, hey, what drugs shall I give? This patient have already had several treatment. So what I need to do is I need to biopsy the tumor, okay, biopsy the tumor, and quickly send this sample to overseas. In this case, there's a lab in Singapore. We send it to the lab in Singapore. They build a 3D model of the cells, and then from the 3D model, they will do chemosensitivity or drug testing. So I will say, okay, I will give them a list of 10 drugs that I want to give to this patient. And then they will give me a score to say, hey, if I use drug A, my chances of success is 70%. If I use drug B combination, my chances of success is 5%. So based on the percentages, then I can select the best treatment for the patients. So there are many, many different types of profiling. So PAM50 is one of them, looking at early stage of breast cancer, early stages of cancer, and then you have the NGS, and then also you know, uh, this in vitro Q study looking at later stages and deciding specifically on certain drugs and certain treatment, looking for druggable targets or drugs that gives the best chance of success. So it's quite complicated, quite complicated.
Yeah. Thanks, Dato, for answering that
Okay.
question. I think the next question is I have two final questions. This one is
Mhm,
actually related to the trial that you mentioned earlier, Optima, right? So for trial
mhm.
participants for HR positive, can we be part of the trial participant if they have completed treatments including Herceptin?
Unfortunately, no, we are looking at patients who are upfront, who are treatment naive, and those who are actually have already been treated. Yeah, it's in the exclusion criteria. Sorry.
Okay. Sorry about that, Divan. And then cousin had one last question. Earlier you mentioned that you recommend more aggressive treatment for those younger patients below 35. So if the said patient is age 33, grade 2, stage 1, ERPR high positive, HER2 negative, PAM50 recurrence only 2%, still need more aggressive treatment and BRCA negative.
Okay, I think this is again. I think the treating oncologists have to make that decision. I mean, it's difficult for me to. It's not fair, and it's not also ethical for me to
Yeah.
make such a comment online like this without seeing the patient, understanding the full details. And I think I'm sorry, like, it's not a good idea. I think it's best. I think your oncologist will be the best person to decide on this treatment. So I would go by the advice of your current oncologist.
Yeah. So unless you seek a second opinion, then you can make the evaluation on your own. So thanks a lot, Dato. I think that was the
Thank
last
you.
question I was going to take. You've spent a lot of time with us today. So
My
thank you all for
pleasure.
your
Yeah.
questions. I really, really appreciate it when all of you want to be more aware. And this public education program is definitely something that both Dato and myself and Innovation Diagnostics wants to bring to all of you. To understand more about breast cancer, early stage breast cancer, and whether chemotherapy is needed, and of course, prognostics and recurrence rates. So we hope that you've gained a lot during this Pink October session, and we hope that all of you will be more aware of your health and your breast for women. Thanks a lot for joining us, and thanks a lot, Dr. Ibrahim, for
Thank you.
actually
My
helping
pleasure.
a lot of patients out there and being on today's show. Thank you so much. And for
Thank
those of
you.
you who tune
Thank you
in
very
almost every
much.
Sunday, I'll see you guys in 2 Sundays' time. And if you're a parent, I think it'll be a very interesting session for you. Thank you so much, Dato. You've been a great help. Really, really
Thank you.
appreciate
Thank
it.
you very much.
Have a good
Thank everyone
Sunday.
for
Thank you.
joining. Thanks
Thank
for
you. Thanks,
everyone. Thanks everyone
everyone.
for
Thanks,
joining. Yeah.
Dato. Have a good Sunday,
Thanks.
everyone. Bye.
Thank you. Bye. Bye.